President. Endoscopic treatment for emphysema is a new form of minimally invasive therapy with the aims to achieve the benefits of LVRS without the morbidity or mortality. And it is presently being pursued by several companies and is undergoing clinical evaluation. There are two concepts with endoscopic treatment for emphysema. The first concept is the usage of one-way bronchial valves, which are placed within the lumen of the airways and is targeted at patients with heterogeneous emphysema. Our next speaker will be Darkwood, will be speaking to us on this area. And the second concept is on airway bypass, which is targeted for patients with homogenous emphysema. These are the 5 different areas which I'll be going through regarding airway bypass. Airway bypass is the creation of transbronchial fenestrations between destroyed emphysematous lung and communicating with segmental and subsegmental bronchial airways. The procedure involves using a probe to exclude peribronchial blood vessels. A transbronchial fenestration is then created using a needle and balloon dilatation device. An airway bypass stent is then placed to keep patency of the fenestration. This shows airway bypass in a patient with emphysema, and importantly, it shows communication with destroyed emphysematous lung. The concept of airway bypass is that they act as new alternate pathways, taking advantage of collateral ventilation, allowing for trapped gas to escape, thereby reducing hyperinflation in patients with severe homogeneous emphysema. Initial experimental studies that were performed by the group at Washington University in St. Louis, using 12 explanted emphysematous lung from lung transplant recipients that were evaluated in study chamber, shows initial baseline forced expiratory volume, an improvement in forced expiratory volume after placement of 3 stents, and further improvements with 2 additional stents. Similar improvements were also found with forced expiratory flow. In another separate experimental study that was performed at Washington University in St. Louis, this shows an explanted emphysematous lung from a lung transplant recipient before the placement of airway bypass, showing severe hyperinflation from trapped gas, and this shows the reduction in the lung volume following placement of airway bypass stent. And this study was published last year. Having shown that in experimental studies that airway bypass improved expiratory flow and volume, the next step was to assess the feasibility and safety of airway bypass stents. And in this animal study, 70 stents were placed in 12 dogs. There was 1 pneumothorax. There were no significant complications, and there was no mortality. The study also evaluated the stent patency with weekly topical mitomycin application. And this prolonged stent patency, and in contrast, all the control stents were occluded after 1 week. The next step was to evaluate paclitaxel-eluting airway bypass stents in terms of prolonging stent patency. And in this other animal study, 157 stents were placed in 25 dogs. Each dog has both control and study stents and had bronchoscopic follow-up at intervals. There was no mortality and no significant complication, and there was no delayed complication with the usage of paclitaxel-eluting stents. The study found that it was feasible and safe to use the paclitaxel-eluting airway bypass stents. This shows stent at the time of placement, and this shows an occluded control stent at 1 week follow-up. And in contrast, this shows a patent stent at 3 and 13 weeks follow-up. And these stents were placed in dogs with normal bronchial airways and lung. The green line represents the control stents, and 80% were occluded at 1 week follow-up, and the remaining stents were all occluded by the 4th week of bronchoscopic follow-up. In contrast, 2/3 of the stents, the study stents, were still patent at 18 weeks follow-up. Based on this experimental study, paclitaxel-eluting airway bypass stents were utilized for clinical evaluations in patients. Having shown that airway bypass improved expiratory flow and volume in experimental studies, and having shown that it was feasible and safe to perform airway bypass in animal studies, the next step was to evaluate the feasibility and safety in patients. And this was a conjoined work from the group from Rome and also from Washington University in St. Louis. In 10 patients undergoing lobectomy, 29 passages were created, and there were no significant complications and no mortality from that. And in another 5 patients undergoing lung transplantation, 18 passages were created with no significant complication or mortality. The study showed that it was feasible and safe to perform airway bypass in patients. And the next step was to evaluate the clinical application of airway bypass in patients with severe emphysema. In this study, 35 patients were treated, 264 stents were placed with 6-month follow-up data. And I want to bring to your attention a subgroup of patients with severe hyperinflation who had better results. This shows improvement in residual volume in the entire group of patients, and there were better improvement in the subgroup of patients with severe hyperinflation. There were similar improvements in FVC in the whole group of patients, and again, in the subgroup of patients with severe hyperinflation, the improvements were more marked. The study found that airway bypass reduces hyperinflation, and the subgroup of patients with severe hyperinflation benefited the most. And based on this study, a pivotal trial was carried out. And in this EASE trial, it is a randomized double-blinded study targeting patients with severe homogenous emphysema using the paclitaxel-eluting airway bypass stents. It commenced in 2007, and recruitment completed in spring this year, and 320 patients were recruited worldwide as a multi-center study with a 2-to-1 randomization. The 6-month analysis is near completion and would soon be available to some of the investigators. In conclusion, airway bypass has been shown to be feasible and safe in both animal and human studies. It is targeting patients with severe homogenous emphysema, and the improvement seems to be more marked in patients with severe hyperinflation, and the EASE trial data would soon be available to some of the investigators. Thank you.
Thank you very much, Cliff, and congratulations. So we have seen solution number 1, the very elegant solution which is proposed for homogeneous emphysema. We shall see now solution number 2, which is